Mr. Yolfison?
Right, thank you, Mr. Chair. Thank you both for coming. This is very useful to us. And likewise, Dr. Quinn, thank you particularly for coming forward and for your candor about your struggles. And I know this must make things much more difficult for you. Now, we're talking about the diagnosis of Mefloquine toxicity. Right now, we are dealing with a lot of literature that says there are some associations. I haven't been able to get a really pin down anyone from an answer as to how can I look at patient X and say this patient's symptoms are Mefloquine toxicity. In fact, this is from the Australian Senate Committee report that was just tabled in March of 2019. And it says, specifically says in this report, there is no specific way to diagnose chronic Mefloquine toxicity effects as many symptoms are shared with other conditions such as PTSD. So how do we reconcile that when there's such a statement like that?
I think that statement is somewhat simplistic. So there are a set of diagnostic criteria that include both neurological as well as neuropsychiatric symptoms.
Okay, and where can we, sorry to interrupt, I have very limited time. Where can we find this diagnostic criteria published? Is it a generally accepted by the medical profession as a diagnostic criteria?
So I think that's what I said in my opening statement, that it doesn't appear in any of the diagnostic manuals.
Yes.
However, the accumulation of symptoms has been published on numerous occasions, both in case reports and also in articles that have taken into account broader populations.
No, I understand that, but that doesn't necessarily mean that this is defined as a diagnostic criteria if there's a number of literature describing it in a number of case reports. If it's not in any diagnostic manual, how are we supposed to, again, how do I, as a physician, say, patient X is in front of me, to know that, this person who came back was deployed, took Mefloquine, how do I tell that patient X is suffering from Mefloquine toxicity versus PTSD? How can I find that out in patient X that's sitting in front of me?
So there are a number of specific differentials, one of which is vestibular disorder and a central vestibular disorder, the others of which are the particular types of vivid dreaming states and neurocognitive decline that are observed in patients suffering from after exposure to Mefloquine. The other key diagnostic indicator is whether or not a person had a reaction at the time to taking the drug. In other words, they had a different health status prior to and immediately prior to taking Mefloquine, and that health status changed at the point at which they took the drug. And that's a key critical indicator to identifying those who have been directly affected. And I think Professor Sellers will probably have something to add to that as well.
Okay, Dr. Sellers?
Yes, I think that Professor Quinn is nudging up to what you have to do, and it's really the assessment of whether the drug has caused a reaction. And in this case, we know the natural history, that an acute reaction is associated with a probability of a longer-term reaction. So you need to know, was the drug given? What dose was it given? Was it actually taken? How long was it taken? What are the risk factors that an individual has? What is the uniqueness of the symptomatology? What's their past history of anxiety, depression, and so forth? And if you do that systematically, you can determine whether Mefloquine was involved in the evolution of the symptomatology. I mean, it's nice to have a diagnostic category, but with neuropsychiatric kinds of issues, you're going to have a mixture of signs and symptoms.
Okay, thank you.